Okay, so picking up where we left off today, today 627, we're going to be working on blood flow and pressure mainly today. But real quick, before we get into the arteries, the veins, the capillaries again, factors that affect flow and pressure, I did want to go back real quick and finish up some of the material that I had left over from cardio phys. And it's not a large amount of material, but it does apply to certain questions that you might end up getting in the future, not only on our test, but on standardized type testing. And it usually has something to do with heart valves and murmurs. So we're going to go over that really quick. And once we get done finishing that material up, we'll go ahead and jump right into blood flow and pressure. So again, this is week 5. We just started lecture 2 material last week, where we were basically going through most of the normal cardio phys, and then we did the patho phys separately, where we talked about normal blood flow through the heart, and then, what would we expect if it's abnormal? Like if we can't even maintain separation of chambers, like if you have an interatrial septal defect and you got blood coming into the right atrium and it immediately skirts over to the left atrium, what would that be an issue, or why would that cause an issue? So, just knowing regular blood flow through the heart, knowing normal conduction system, knowing normal setup where things are supposed to go from beginning to end. And then what would happen if the heart got backed up, like with congestive heart failure? Where are you going to back up into? So that's mostly what we covered last week. This week, as a whole, we're going to be working on blood flow and pressure in just a little bit here. We're going to do respiratory system and gas exchange. Next week, we're not really covering any material. It's essentially just a review week. So we don't have class on Tuesday. That's going to be where the 4th falls. On Thursday, we'll do our Zoom Q&A. I don't foresee us, not finishing the material. Both of these chapters are fairly brief, at least with the amount of time that we have to go over them. So if there is anything left over, then yeah, we can pick it up right here, but we'll probably just use this as a Zoom Q&A type class. So if you got any last minute questions about lecture 2 material, that's what we'll use that class for. But anywho, again, today we're right here. And before we get into blood flow and pressure, I'm just going to finish up the last little bit of cardio phys. And my PowerPoint's already open, so I'm just going to switch screens rather than going through the whole download. And let me show you, I've actually already scrolled down to it as well. This is kind of what you're seeing on my screen. But where we left off, or at least what I wanted to talk about, kind of starts right here. So this is where we want to start going over things, and I'm probably going to do most of this on the paper over here, but this picture we want to look at, and leading into this, kind of the segue that leads into this, it talks about heart exam. And heart exam's a little bit different because sometimes if you're suspecting that there might be an enlarged heart, that would change where you would listen to things. But most of the time when you examine patients, we tend to like to go from a least invasive to a most invasive type of order, where the least invasive things I do is just look at the patient. So that's kind of like observe. In most other places in the body, especially around the GI tract, usually the second least invasive thing we could do is stick a stethoscope to them and auscultate. But with the heart, it's a little bit different, because if the heart's not in the exact right place that we expect it to be, or if the heart's enlarged, then that would change where we auscultate. So when you do a heart exam, you actually do observation, what's called palpation and percussion next. Palpation is just where you touch a patient to see what you feel. If it feels hot, that's, an observation you could make about them, like just using your hands. Like when you're just looking at them, we're probably looking for redness, maybe discoloring in some way, shape, form, or fashion. Is there bruising around an area? Is there a visible lump? And then when you're palpating, you're feeling for maybe something that's not so visible, but you can feel it with your hands or the tips of your fingers. So palpation's just feeling stuff. Percussion is where you beat on the patient a little bit. There's different types of percussion that we can use, but a lot of times, if you're using just fingers, and you're trying to listen for the borders of the heart, sometimes we'll just kind of tap on our fingers like this. And when you're over solid objects in the body, the tap will be a little bit more dull. And when you're over air pockets like the lungs, then it's going to have more, I guess, kind of like an echo type sound to it. So when you're palpating, you're just feeling. And then when you're percussing, you're hitting something. So again, percussion can change depending on where you are in the body. I mean, you have like a percussion hammer right here that you could use for like deep tendon reflexes. But when you're talking about percussion for, say, like a thoracic exam or abdominal exam, we're probably just pushing into something or just tapping on something to see how it sounds. But anywho, when you actually get out the stethoscope, let me go back to the page. That's what we call auscultation. So here we're just listening. Like obviously with the percussion, we're kind of listening too, because we're trying to find what's called borders of the heart. You'll learn all this eventually. But when you're auscultating, this is where you actually get out the stethoscope. And a lot of times what you're listening for with the heart is just normal closure of the valves. So we'll get into that. We'll talk about it. So I'll write it down on my piece of paper here so I don't forget to mention it to you, S1 and S2. Let me show you this picture real quick here, because it's a good picture. It's not the exact same place where I would put number 4. A lot of times we'll drop number 4 down here because it's A, easy to palpate, B, it's a little bit more accurate. But I'll give you some words to memorize. So when we listen to the heart, like when I get out the stethoscope and I'm listening for valves closing, like S1 and S2, the lub dub or lub dup, whatever you want to call it, this is the order that I go in. So 1, 2, 3, 4, 5, right? And again, usually number 4 down here will drop down to this little area right here. But this is the order we're going to go in. And when you're listening in this order, you're listening to the aortic valve first, followed by the pulmonic valve, followed by something called Erb's point, followed by the tricuspid valve, followed by mitral. And it's not necessarily where these things are anatomically located. It's just the best place to listen to them, right? It's the best place to hear them. So there's a little mnemonic called a pet monkey that reminds you of the order that you go in when you're auscultating the heart, right? So listening with the stethoscope. So when we do our a pet monkey, what we're listening to is the normal closure of the valves. So your first heart sound, or your S1, is AV valves closing or slamming shut, right? So when the valves seal off, they go like that. So when we're listening to it through the stethoscope, you can hear the lub sound. Second heart sound, S2, this is semilunar valves closing. So these are both valves, AV valves closing and semilunar valves closing. And so that's usually going to be due to the back pressure that's coming from those major vessels that we're pushing into. So whenever the heart is compressing the blood, like your heart's a muscular sac, and inside that sac we have fluid, right, which is blood. And when you try to compress fluid pushes back really hard. Fluids are usually as small and compact as they're going to be in their normal state. You can't really compress them very much, right? And so water is one of those things that we use a lot because of that property. Like if you ever hear about like hydraulic pressure, that's the idea of trying to compress water, and water just pushes back. It's like, nah, I'm not going to get really any smaller. So let's just push this force somewhere else then. So when the heart is compressing the blood, what it's trying to do is overcome another pressure that happens to be in front of it. So for example, I know we're kind of on a tangent now. That's just how my brain works. When I'm trying to go from the atrium to the ventricle, at first, it's no problem. It's very easy because as you're going through diastole of the heart, you're just refilling. And when blood is coming back into the atria, the ventricles had just pushed blood out. Systole had just occurred and these things had emptied. right? So there's very low pressure in here, there's very low pressure in here. So as blood's coming back in, there's really no pressure to overcome because everything that generated pressure before is empty, right? So blood will start filling up the atria, that'll just passively go into the ventricles, and eventually the pressures between these two sets of chambers, between the atria and the ventricles, will equalize. So you end up having to go through what's called atrial systole to finish emptying the atria, finish filling the ventricles. So that's kind of like the first pressure we have to overcome. But the main pressures we usually end up talking about with systole and diastole is what are the ventricles pumping against, you know? And when we finally finish filling these ventricles, there's already going to be a lot of pressure in here just because of the fluid volume that happens to be in here. Like the fluid itself is pushing on the walls, the weight of the fluid's pushing on the walls around it. And so since this fluid's already pressurized, that's a good start, but it's still not going to be enough to overcome what's called peripheral resistance, because I have pressure in the lungs that's pushing back, and I have pressure in systemic circulation that's pushing back. Not nearly as much pressure in the lungs, right, as we have pressure in the systemic circulation, right? But those are always pushing back, so we need to overcome that. So a lot of times what ends up happening is right after these ventricles fill up and those AV valves are still temporarily open because we just went through atrial systole, not only is this starting to generate pressure in here, but the heart's going to squeeze on that fluid that's in there to spike the pressure up higher. So that'll slam these AV valves shut, right? And that gives you your first heart sound, right? So essentially we're trying to create some driving pressure that's going to push fluid out of the ventricles toward its destinations, but at the same time, we want to prevent backflow, and that's one of the functions of valves. So our first heart sound is actually closure of one of the sets of valves, the AV valves, right? So your first heart sound, S1, is the closure of these AV valves as the ventricles are about to pump blood out. But before we pump blood out, we want to make sure it doesn't go backwards. So these AV valves are getting slammed shut due to the back pressure, right? Because again, this fluid's pushing in all directions. Okay. So AV valve slams shut. And then during systole, the fluid is going to be leaving. So these AV valves are slammed shut, right? The semilunar valves get pushed open, right? Because the pressure that we generated in here, you already had a full ventricle, which is generating pressure on its own, and then you squeezed on that pressure, that slammed the AV valve shut. Right after that happens, the semilunar valves will open, right? And then blood will start to empty. So during systole, right, the fluid is now leaving the ventricles because it's exiting out and it's going into its destinations. And so in this case, it's heading into the aorta. Over here, it's heading into the pulmonary trunk. But because the fluid is now leaving, and the fluid is essentially what we're pressurizing, the ventricles pressure will drop lower than what we have out here to begin with. So as soon as the pressure inside of here gets lower than what we have out here, back pressure, which is pretty consistent, will cause these valves to slam down and shut. Right? And if you ever get asked, you know, what is peripheral resistance? A lot of times they're asking about, well, what is the left ventricle having to push against? And it's usually pressure that we're finding in that aorta, because your aorta is essentially where all your vessels come from. Which I know that sounds like a wild and crazy idea, but, you know, today you'll kind of see how the aorta develops into all the other vessels. But the back pressure that exists in this aorta is usually, in a normal, healthy individual, right, about 90 millimeters of mercury pressure. And to overcome that back pressure, we usually generate about 120 millimeters of mercury pressure inside the ventricle. That'll help not only open this valve, right, but allow it to empty enough. And then once we drop below this number, like let's say we drop down to 80 millimeters of mercury pressure inside of here, now the pressure out here, because it's inside of here, is greater than the pressure we have inside of here. So that valve gets closed, and that's what gives you that S2 sound, right? So short version. The First heart sound, you got fluid in here, the heart contracts, AV valves slam shut. That gives you your first heart sound, okay? Second heart sound, your ventricles are emptying, right? The blood is exiting. So as soon as the pressure out here becomes greater than the pressure that's inside of here, because we don't have any fluid in here maintaining pressure, then that will slam these semilunar valves, and that gives you your S2 sound. So semilunar valves slam shut. And again, AV valves are tricuspid and bicuspid, or you could say tricuspid and mitral. Semilunar valves are going to be pulmonic and aortic. So, easy peasy. Again, circle diagram explains everything you ever need to know. Everything. I might get me like a golden medallion and wear it around my neck as a circle diagram. And people are going to be like, what is that? And I'm going to say it's the answer to everything that you've ever wondered. I think that would be really cool. You know what I mean? I'm teasing. I don't think it would be cool. But the fact that it's so not cool actually makes it cool again. Because then it's ironically cool. So S1 and S2, we talked about. The next big concept I want to talk about before we get into sites of auscultation is valve positions in systole and diastole. We just kind of showed it a second ago, but let's just kind of show them together. So one of the, again, hidden rules that's not always mentioned in books is, systole we think about as the contraction phase, the pumping phase. Diastole, they usually call the relaxation phase. We're not going to think that way because that's what stupid people do. We're smart. So we're going to say refilling phase, right? So diastole is the refilling phase, systole is the contraction or the pumping phase. When it's not indicated otherwise, these words specifically refer to ventricular systole and ventricular diastole. Okay, there is an atrial systole, but if we're talking about atrial systole, then we'll say atrial systole. If we don't say the word atrial, then we're talking about the ventricles. If we just say systole, I'm just referring to the ventricles, right? So it's an unspoken rule that is now spoken. So during diastole, what valves need to be open? What valves need to be closed? Well, if I'm refilling the ventricles, then clearly AV valves need to be open. Semilunar valves need to be shut, right? Because we're refilling, okay? So refilling. Okay. During systole, we are contracting and we're trying to pump blood out toward our destination. So again, what are ventricles trying to pump to? Well, the left ventricle is trying to pump into systemic circulation. The right ventricle is trying to pump into pulmonic circulation. So those valves, the semilunar valves, need to be open so we can eject blood out, right? But we don't want backflow. So my AV valves should be shut. Okay. So this has nothing to do with S1 and S2. I was just trying to go over a list of things I wanted to talk about before we got to our murmurs. So during systole, which valve should be open? Which valve should be shut? Right? Semilunar valve should be open. AV valve should be shut. During diastole, again, me saying it in long ways is harder than you actually just thinking about it, right? During diastole, what am I trying to do? I'm trying to refill the ventricles. So what valves need to be open? What valves need to be shut? So again, AV valves should be open, semilunar valves should be shut. So it's just common sense. During diastole, what am I trying to do? Refill the ventricles. So which valves need to be open? Which valve need to be shut? During systole, I'm trying to eject blood from the ventricles without any backflow. So which valve should be open versus which valve should be shut? So again, between atria and ventricles, AV valves. Between ventricles and their destinations, semilunar valves. Pulmonic, aortic, pulmonic, aortic, tricuspid, bicuspid, tricuspid, bicuspid. Okay. So circle diagram. Next, when we are listening for heart sounds, what do I want to hear? I just want to hear S1 and S2, right? Because that's what we call normal heart sounds. But there are other heart sounds we can sometimes hear, right? So sometimes you might hear some type of squishing sound or slipping sound or regurgitant sound, like blood splashing back into a place it's not supposed to go. So when you hear other sounds, and if you happen to hear those other sounds over a valve, then usually that's indicating that there's some type of murmur going on. So when we listen to the heart sounds, we typically do it in a certain order. So let me share screen with you again. This is the order that we're listening to. Whatever way you've been taught this in your classes or clinicals, please keep continuing to do that. The way I was taught might be different, so I'm just going to tell you how I was taught. And when we're listening to these different heart sounds, we would use both the bell and the diaphragm of the stethoscope. Let me see if I got a stethoscope sitting around anywhere. I don't think I got one in reach. And I'm probably not going to go upstairs to go get one, but the bell is the part that looks like the bell. The diaphragm is the part that's flat. So a lot of times on stethoscopes, you can get stethoscope that's got two pieces on it, and the flat end is called the diaphragm, and then you'll have this other thicker piece in the middle, and then on the other side, it might have something more like this. So that's called the bell. So bell, diaphragm flat, the bell is the thicker piece, right? So a lot of times you can just flip that around on a stethoscope if you want to. So sometimes the question comes up, well, when do I listen with the bell? When do I listen with the diaphragm? You know, a lot of times it's just personal preference. But, you know, if I'm trying to listen to vessels, this usually is a little bit better, right? If I'm just trying to search for something, the diaphragm's a little bit better. So if it's more hollow, you know, an organ, then, you know, one will work better than the other. But I mean, there's really not a hard rule in the real world. It's just when you're first learning it, you know, you're going to have a certain order you need to memorize. You're going to have a certain number of beats if you're listening to the heart that you got to memorize. And they'll usually, you know, say that we want to listen with this or this. So when I was in school, we listened 15 beats with each bell and diaphragm. Right? So whether you did all 15 beats with just the bell first, boom, 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 and then you flipped it over and did all 15 beats with the diaphragm, boom, 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 boom. Or if you did 15, flip it 15, doesn't make any difference, but that's what we were taught when I was in school. So if I know how many to listen to, the next thing I need to know is where do I listen to it, right? So that's the part we got to learn for our test, because this is how questions might come up eventually. So first place, I'm going to listen. So auscultation sites, that's what we'll call this. We'll call this auscultation sites. The first place I'm going to be listening to is representative of the aortic valve, and it's going to be the first, I'll write it out this time and then I'll abbreviate, intercostal space. So the first rib, or first space between ribs. So this would be between rib 1 and rib 2. That's the first place I can have an intercostal space. So the first intercostal space, right side of sternum. Okay, so if we go back to that picture, that's where that little dot should be. So here is, oh, I'm sorry, I didn't, ignore what I just said. Ignore what I just said. I meant to put second intercostal space. I really did. So second intercostal space, right side of the sternum, is our first auscultation point. That's what I meant to put. I'm sorry. Trust me. I semi know what I'm talking about sometimes. But second intercostal space, right side of the sternum, is our first auscultation site. That's what I was intending to say. And once you find that one, everything else pretty much is easy, right? So, you know, at first, what you'll probably do is you will try to demonstrate that you're looking for that intercostal space on the patient. So, you know, you'll feel something hard and that's going to be a rib, and then you'll feel like a little soft valley, and then you'll feel something hard again and that's going to be a rib, and then you're going to feel a little soft valley. So second intercostal space is going to be between rib 2 and 3, right? So you'll feel rib, valley, rib, valley. There you go. That's second intercostal space. Once you visualized it and seen it once or twice, you don't really need to palpate anymore. You can just stick the stethoscope where you think it's supposed to go, right? Because it would be kind of disheartening, you know, if I was walking into the doctor and they're sitting there trying to like think and palpate, like, where is this that I'm it doesn't portray much confidence. So do it the first couple of times just to, you know, really find it, you know, and then after that you can just eyeball it. But when you're doing your clinicals, obviously follow the instructions you're given. But sometimes just pretending like you know what you're doing really helps. It really helps. They're like, oh yeah, he looks like he knows what he's doing. He's fine. So first auscultation site is going to be listening to the aortic valve, and it's the second intercostal space, right side of the sternum. Okay. Second auscultation site, we're going to be looking for a pulmonic valve. So again, a pet monkey is going to remind you of what you're listening to: aortic, pulmonic, Erb's point, tricuspid, mitral. And a lot of times, a lot of people skip Erb's point. And then you're listening to tricuspid and mitral. And a lot of times at first, you have no idea what you're listening to. And even after a couple of years, you still have no idea what you're listening to. You're just like, does that sound kind of normal like everybody else's, or is there something really weird about that? And then eventually you're like, oh, okay, I know what that is. But yeah, first while you're just faking it till you make it, but try to figure out what it is. Try to distinguish, you know, what am I really listening to? Why could that be there? But yeah, don't freak out when you feel like you're the only one that doesn't know. So pulmonic, where's that going to be? Second intercostal space, left side of sternum. So this is what I was saying a minute ago. Once you found the first place to auscultate, which is second intercostal space, right side of the sternum, now all I got to do is slide the stethoscope over. And then I'm going to drop it down one, drop it two more spaces, and then slide it over again. So once you found the first auscultation site, everything else becomes easy. So let's just imagine this is the sternum right here. Let's say that's rib 1. I know it's hard to see. Let me darken them. So that's rib 1, that's rib 2, that's rib 3. Here's your first auscultation point. Second intercostal space, right side of the sternum because the patient's facing towards you. So again, this is right, this is left, just like we draw the pictures of the heart. So once you find that, now all I have to do is slide the stethoscope over. So here's second auscultation point. So second intercostal space, right side of the sternum. This is second intercostal space, left side of the sternum. Third intercostal space, left side of the sternum. Fifth intercostal space, left side of the sternum. Fifth intercostal space, mid-clavicular line. So once I find one, easy. Okay, so let me go back and write what those are. So second intercostal space, left side of the sternum. Your third auscultation site is going to be what's called Erb's point. And it's kind of a place, you know, they'll say it's the best place to hear this or the best place to hear that. It's more or less a place where you're kind of in between AV valves and semilunar valves, so you can kind of hear both of them equally, right? These other places I'm going to be hearing, you know, aortic valve best, pulmonic valve best. Here I'm kind of in between AV and semilunars, so you can hear both sounds equally well, but not as good as you could at any of the particular points, right? But that's still got some usefulness to it. So this is going to be third intercostal space, left side of the sternum. Everything stays left from now on. Right. Here's where my list is going to differ versus what's on the screen here. So this is going to put it at fourth. I always learned fifth. Okay. So my fourth auscultation site is going to be the 1, 2, 3, 4 tricuspid valve, right? And all these are valves. So aortic valve is what I'm listening to, pulmonic valve, Erb's point's not a valve, but it's between valves, tricuspid valve, and then eventually your mitral valve is what I'm listening to. Tricuspid, fifth intercostal space, left side of sternum. And again, the picture looks a little bit funky, but it's usually where your sternum is stopping and forming an angle. So in the real world, not necessarily what the diagram is showing, your sternum, if you remember, has different parts to it, right? You got like a manubrium, you have a gladius, and then you have a xiphoid process. And the xiphoid process is kind of like a little dangly thing right here. Between your manubrium and your gladius, this is called your sternal angle or your angle of Louis. That's an anatomical landmark where the trachea is bifurcating to go out into the principal bronchi. So that's an important anatomical landmark. But your fifth intercostal space should be right about here. So you'll feel the sternum kind of stop, and then you'll get an angle between the sternum and the rib right there. So that's where you put your stethoscope. It's basically where the rib cage feels like it's kind of stopping underneath the sternum right there. I mean, it's not, obviously it's not, but still, that's what you're feeling. But again, that is going to be the fifth intercostal space, still right up alongside of the sternum. And then the mitral valve is going to be the fifth intercostal space, what we call mid-clavicular line. Okay. So that is why it's moved over here. So now we're kind of away from the sternum. Here's that little space I was talking about, a little space. But mid-clavicular line, so again, this isn't right on it by any stretch of the imagination. This picture is a little bit, kind of wonky. But here's the clavicle. Here's the middle of the clavicle. So just drop it down. It should be around the nipple. Right? So on a male, it's right where close to where a nipple is. Right? So just stick it on if it's a male, just stick it on his nipple. So that's the sites of auscultation. So the first site of auscultation, second site of auscultation, third site of auscultation, fourth site of auscultation, we dropped ours down one. Fifth site of auscultation is aortic, pulmonic, Erb's point, tricuspid, mitral, or a pet monkey. Where do I palpate before I stick the stethoscope there when you're showing somebody that you know how to do it? This is second intercostal space, right side of the sternum, second intercostal space, left side of the sternum, third intercostal space, left side of the sternum, fifth intercostal space, left side of the sternum, and then fifth intercostal space, mid-clavicular line, right? So I just kind of find the space and then I just go zoop. So you can just take the clavicle. If you want to visualize this, like if this is your clavicle, I'll share the screen with you in a second. Take the clavicle with your fingers, squeeze your fingers together. There you go. Drop a line straight down. So imaginary line. So here's the clavicle, swoop. Now it's mid-clavicular, right? In between, drop a line. Anyway, so if I were to ask you what site of auscultation would I find at the fifth intercostal space, mid-clavicular line, right? Just go through your pet monkey and you're like second intercostal space, right side of the sternum, right? So let's say left. So second intercostal space, right side of the sternum, second intercostal space, left side of the sternum, third intercostal space, left side of the sternum, fifth intercostal space, left side of the sternum, fifth intercostal space, mid-clavicular line. So it's mitral, right? So second right, second left, third left, fifth left, fifth mid-clavicular line. Okay, left. So that's how you know what you're listening to. Okay, so a pet monkey helps you memorize the order that we're going in, and it's literally, it's just kind of dropping a line down the chest. Start on the right side with one of them, and then everything else is on the left side. So it's not hard to remember. But that's what that picture's showing you. Okay. Next thing we wanted to talk about, we already talked about normal valve positions during systole versus diastole. So if I'm trying to refill ventricles, what valves need to be open, what valves need to be closed, right? If I'm trying to pump blood out of ventricles, what valves need to be open versus what valves need to be closed. So here's the semilunar valves right here. Here's the AV valves. So those should be slammed shut. Those should be open. And here during diastole, I'm trying to refill ventricles. So these valves should be open. These should be shut because we're refilling. We're trying to generate pressure. We don't want it to seep out. Okay. So real quick, before we get into murmurs, which are abnormal heart sounds heard over valves, we have to talk about, well, what are valves normally supposed to do? Okay. So valves have two functions, right? Most of the time, one of the functions gets talked about. So the first function that usually gets talked about is to prevent backflow. But Oscar in the background snoring, just like half of y'all are probably doing, right? So first function of a valve is prevent backflow. That's the one everybody talks about. But what good is a valve if it doesn't allow a single direction of flow? So it has to be able to allow single direction of flow. So valves work very similar to doors on hinges, right? Like let's say that this is my door right here. Here's my kind of my door frame. Right? Let's say our little hinge is right here. Right? There's my little hinge. So if I want to enter the room, right, this door needs to be able to open, right? What good is it going to be if I can't even go through the direction I am intending or supposed to go through? And then let's say once I'm in here, I want to lock the door. Well, I should be able to shut this door back and it should prevent it from being able to be open the other direction. So a valve works very similar to how doors kind of set in a door frame on a hinge works, right? Got to be able to open it, right? But at the same time, it needs to also be able to close. Okay? So two basic functions of valves. And that's assuming that the valve is normal and healthy. But what if somebody had some type of heart infection? Maybe they had some type of bad strep infection, somehow got into the heart and the heart itself got inflamed, and then you end up having a messed up valve. Or let's say that you have cardiomegaly, and because the heart has become misshapen now and grew, the valve wasn't able to keep up. Valves aren't normal metabolically active tissues. It's mostly connective tissues, you know, a lot of cartilage, again, other connective tissues, very fibrotic. So they don't grow similar to how more living cells grow. So when the heart grows, the valve's not necessarily going to be able to keep up. So if you've got bad cardiomegaly, your valve might not shut very good anymore, right? So the valve just isn't the right shape or size it should be to support that enlarged heart. But again, assuming a valve is normal, it should serve two purposes. Not only should it allow a single direction of flow, it should also prevent backflow. But when we get damaged valves, right, then a valve can be damaged in two ways. So damaged valves usually can either become, damaged valves can usually either become what we call stenotic versus regurgitant. Okay. And a stenotic valve opens, but it doesn't open enough. It's too narrow. That's what stenosis means, narrow. So a stenotic valve opens, but doesn't open enough. Versus a regurgitant valve, it'll still close, but it doesn't close enough. So they're faulty valves. So there's two ways we can have faulty valves. I can have a valve that's too swollen, too thickened, too fibrotic, and it becomes stenotic. So not only does it not open very well, it doesn't even move very well, right? So that's going to create extra pressure where you don't want it. So it opens, but it doesn't open enough. We know it still opens because I can hear blood going past it. But because that blood has now become more turbulent, I can hear the blood as it's trying to squeeze through that narrow valve. So that's going to lead to a murmur, right? So how can you tell if a patient has damaged valves? Well, the valves themselves were what's generating S1 and S2. And normal valves should sound like this: lub, dup, lub, dup, lub, dup, lub, dup. But if I have a damaged valve, you're going to hear something extra. So I might hear lub, dup, lub, dup, lub, dup, right? Or to sound like, right? It's almost like a quick seashell type sound sometimes. Maybe it's a, you know, a gurgling sound. So what's wrong with the valves? Well, I might not necessarily know, but I know they're not working appropriately because I'm hearing an extra heart sound. Because if my normal healthy valve is working appropriately, I should just hear S1 and S2, right? But if I'm hearing something extra, then it could indicate that our valve has either become stenotic or regurgitant. So a stenotic valve creates turbulent blood flow because it's literally just too narrow and you're trying to push too much blood through an opening that's not opening well enough, right? So that creates too much friction. If you have a regurgitant valve, that means it's closing, but under pressure, it'll allow blood to seep back through. So when that blood seeps back through again, that's going to create again another sound, right? So stenotic valves are damaged valves that open, but they don't open enough, creating turbulent blood flow. Regurgitant valves are valves that close, but they don't close enough, so blood's able to seep back in. So you can hear that blood pushing back through. And you can have stenotic or regurgitant valves over any of the valves. You can have aortic regurgitation, you could have aortic stenosis, you could have pulmonic regurgitation, you could have pulmonic stenosis, you could have tricuspid regurgitation, you could have tricuspid stenosis, you could have mitral regurgitation, you could have mitral stenosis. Right? So when they ask questions about murmurs, they have to give you a little bit of information. And a lot of times, if you don't know a mnemonic to help you with this information, it takes forever to answer questions about murmurs because you have to go back and you have to draw the picture of the heart in systole versus diastole. You have to see which position should that valve be in that, at that particular time. And then you have to be able to answer what valve am I listening to? And you have to go through APET monkey, which that is quite useful. And then you have to be able to determine what that murmur is. So to circumvent all that, what I usually teach people is the arms and parts murmurs, which will help you learn all murmurs that you can have during diastole. So if you get any questions about murmurs and they tell you you're in diastole, because they have to give you certain information. Like in a written question, they have to give you a certain amount of information if they're going to ask about murmurs. They have to tell you which phase of the heart cycle are we in? Are we in systole versus diastole? They have to tell you where you're listening, either directly or indirectly. So they can either say, I am listening to the second intercostal space on the right side of the sternum, or they can just say, I'm listening over the aortic valve, one way or the other. And then they have to give you the phase of the heart cycle in some way, shape, form, or fashion. They could say during refilling phase or relaxation phase or contraction phase. But it would just be simpler if they just said systole or diastole. But arms and parts are the 4 types of murmurs that I can have during diastole, right? So again, let's look at diastole. Which position should these valves be in? Well, if I'm trying to refill the ventricles, get some sunlight peeking through here. If I'm trying to refill, it's the glow off my halo. So if I'm trying to refill the ventricles, then these valves need to be open. These valves need to be closed, right? But if I have a faulty valve, maybe it's not open enough. So these can become stenotic. Or another way we could have a faulty valve is if they're not closed enough, right? So it's closing, but maybe it's not closing enough. So they would become regurgitant, right? So again, in our circle diagram, this is tricuspid. This is going to be bicuspid or mitral. So we're going to say mitral this time. So we'll say tricuspid, mitral, pulmonic, aortic. So again, we don't have to do this. I'm just showing you what this represents. So during diastole, there's 4 types of murmurs I can have. I could have aortic regurgitation. Well, that makes sense because aortic valve should be shut, but if it's not shut enough, then blood could seep back in, which would cause a regurgitant murmur. I could have pulmonic regurgitation again, right? Pulmonic valve should be shut, but if it's not shut enough, then back pressure can send blood back through and you're going to hear that blood squeezing back through, right? Or you could have tricuspid stenosis. Well, that makes sense because tricuspid valve should be open, but if it's not open enough, that means it has become too narrow, right? Then blood's going to have a hard time squeezing through here, right? So that could create a murmur. So tricuspid stenosis. And again, if mitral valve has become too narrow, it's going to be harder for blood to squeeze through there, so you would have mitral stenosis. So those are the 4 possible murmurs you can get during diastole. Aortic, pulmonic regurgitation, tricuspid mitral stenosis, arms and parts. All right. So how can this be asked? Patient presents with extra heart sound over second intercostal space, right side of sternum during diastole. There you go. So if a patient presents with an extra heart sound over the second intercostal space, right side of the sternum, first thing I need to do is figure out what valve are we listening to. So right here. So that's aortic, right? So aortic, pulmonic, Erb's point, tricuspid, mitral. So aortic, pulmonic, Erb's point, tricuspid, mitral. So if it's second intercostal space, right side of the sternum, there's only one. So aortic, right? They told you it's during diastole. So now apply your mnemonic. Whatever is beside the A, go with that. Okay. So what if it's during systole though? If it's during systole, valves have changed position. So if it's during systole, AV valve should be shut. Semilunar valve should be open. So if I'm hearing a murmur over valves that should be shut, but they're not shut enough, then that's regurgitant. So these are going to be regurgitant murmurs. And if I hear a valve or a sound, extra sound over a valve that should be open, but it's not open enough, then it's stenotic. So these have now become stenotic. So that would be pulmonic, right? Stenosis, aortic stenosis, mitral regurgitation, right? Tricuspid regurgitation, right? So you just switch the letters. So if diastole equals arms and parts, then systole is the R becomes an S, the M becomes an R, the R becomes an S beside the P, and the S becomes an R. So all you have to do is flip them. So now, doesn't matter what I ask you. If I say I hear an extra heart sound, so patient presents with extra heart sound, 5th intercostal space, let's say left side sternum, during systole, what are you listening to? So aortic, pulmonic, Erb's point, tricuspid, mitral, we're listening here, right? We're listening here. So aortic, pulmonic, Erb's point, tricuspid, that's 5th intercostal space, left side of sternum, not mid-clavicular line, right? Just left side of the sternum. So that's where I'm listening. So tricuspid, right? During systole, so if diastole I know is ARMS, PRTS, arms and parts. Tricuspid regurgitation. It'll save you a million years. And you can use that extra time that you're going to gather back for answering other questions. So it's a lifesaver if you know those mnemonics. Because again, you would normally have to think about this, right? And then what valve position should I be in? Should it be open? Should it be closed? You don't have to think about any of that. Just apply your mnemonic. Did they tell me I'm in systole or diastole? If it's diastole, fantastic. Which valve am I listening to? Aortic? All right. Aortic regurgitation. Piece of cake. But again, arms and parts is for diastolic murmurs. If you are told it's systolic, then you have to just flip the R to an S and the S to an R. Easy peasy. Let's see. So little thing, here we go. So could a faulty valve cause a backup of blood when blood backs up, consistently? What do we call that? So believe it or not, you can actually get left-sided heart failure from a faulty valve. So what that question's actually asking is, if I have a faulty valve, and let's say one of the mainstays of a valve is when it closes, it's supposed to prevent backflow. What if my mitral valve doesn't close very well under pressure, right? So if this valve itself is faulty, I'll just put a little X beside it, and we're trying to generate a ton of pressure in this left ventricle, sure, we'll be able to get some blood out, but every time that the heart beats, a little bit backs up. That's a problem, right? Because eventually this is going to accumulate blood and pressure back here, and the pressure is going to increase in this atria, which is eventually going to start to increase pressure that's coming in through pulmonary veins, and that's going to increase pressure in the lungs, which will then increase pressure that the right side has to pump against. So this is basically going to be another way that somebody could have left-sided heart failure. So you can actually obtain left-sided heart failure by having a faulty mitral valve. So if somebody ends up having mitral valve prolapse, it's another way that you can have left-sided heart failure in the absence of cardiomegaly, perhaps, right? Maybe they don't have hypertension, but for some reason they're still backing up. That could be another way. So what should I see or hear on that patient that's experiencing signs of left-sided heart failure, even though everything else is absent? Well, I should be able to hear an extra heart sound over the faulty valve. Right? So again, a lot of times when you're evaluating patients, not any one test is going to tell you much of anything, but they sometimes call it the preponderance of evidence. You know, when you have a lot of things that are all kind of pointing toward one thing, then you're like, okay, that sounds good. Let's start treating that. See how treatment goes, and then we'll reevaluate it again if treatment's not working. Because if treatment's working, who gives a crap what it is? Saves you a little bit of time and effort. So that answers this. And that was the end of the cardio phys stuff. So I know it took some time to go over that, but the blood flow and pressure is pretty short. So let's just go ahead and take a quick break now. We'll take a quick break and then we'll just do this PowerPoint separately. And I've already got mine open, but let me close that one and we'll do this in just a jiffy. So picking up where we left off, we are going to work on this next section. And I gathered that from here. It's the PowerPoint that we're working on. So murmurs, what we had just finished up from last week's discussion, that was still part of this PowerPoint. So where it had the sites of auscultation, the arms and parts, all that kind of jazz, that was still part of cardio phys. And then today's really brief presentation is blood flow and pressure. So again, a lot of this I can draw just to speed things up a little bit. If not, obviously you can just read through the PowerPoints. I usually just try to keep it a little bit different than just reading directly off the slides to you. But it's not a hard read, it goes over a couple of different diseases. We're going to start getting into a lot more diseases coming up pretty soon here. Most of the first parts, we're just kind of sprinkling them in as we see things. We describe them, we'll show it how it breaks. But as we start to get into some of the later chapters, they're going to be a lot more disease heavy. Like some things are very simple, like when you get into the digestive system. I mean, it's complicated if you make it complicated, like when you get into hormones and reflex mechanisms and all that kind of stuff, and you know how blood flows to the digestive system and flows back. But ultimately, it's just a tube where you have stuff going in a very direct path, you know, and it's always repeating the same thing over and over again. So when we don't have so much physiology to cover, we can focus a lot more on the diseases. Unfortunately, with neuro and cardiovascular, you really have to have good, I guess, basics. You have to have good foundation. So we have to do a lot more review, and we're just trying to get everybody on the same page with that stuff. But with blood vessels, this really isn't a ton of difficult stuff. I mean, there's certainly some things to think about, and we do have a couple of diseases that are kind of sprinkled in there again. So things like nephrotic syndrome, kwashiorkor, peripheral artery disease, Buerger's disease, abdominal aortic aneurysm. So it certainly talks about different things that can happen to vessels, but it's still not super rich or super deep in the different types of pathologies. Obviously, clots are going to be a big deal in a hospital setting for sure. But still, overall mechanisms pretty straightforward. Discussing arteries and veins are pretty straightforward, but there's bigger implications. So we're going to spend a little bit of time on that. But a lot of this is just, I'll let you read it, and I'll just ask directly off the, pages. What do we call this disease that presents with, vascular claudication? Right now, it's phenomenon associated with smoking, Berger's disease. But a lot of these don't need a lot of explanation. But first couple of slides we have covered before, and we do want to talk about them again because they play into other topics. Obviously, cardiovascular, lymphatic system, urinary system, fluids, electrolytes, all kind of covered with some of these basic phenomenon that we're going to talk about here in just a second. So again, all the terms, all the words that I'm going to use are here in the notes. I'll be drawing it on paper. It's just easier for me to do it that way. But let's talk about arteries and veins first. We don't do a lot of arteries and veins in anatomy 1 or 2, but basic fundamental information about these things is what I want to go over. Arteries versus veins. How are they similar? How are they different? They're going to be made up of the same basic parts, right? Each one has 3 layers, and they're the same 3 layers, basically. This one's more developed though. So the arteries are going to be thicker, right? And that's going to lead to certain properties. Arteries, I'll draw a picture in a minute too. It'll help with the understanding of all these things. When you take arteries, they tend to start very few and they become much more numerous. So we call that something. We call that divergence, or we'll say that they're divergent. Okay? And that actually helps maintain pressure. With that being said, they are thicker, stronger. That also helps maintain pressure. So arteries, if I have to give them a certain property, not only are they carrying blood away from the heart to the body or to destinations, they are our pressure reservoirs. So I'll write that out rather than just abbreviating it. So they're pressure reservoirs. They can generate pressure when I need it. Okay. They are very capable of contracting because they're thicker, stronger. They have a thicker muscular layer. So of their 3 layers, which are fundamentally the same, the tunica media in arteries is much more well developed. So they are much thicker, much stronger. So when you push blood into an artery, it's going to naturally resist that because they're so thick and strong. Veins are going to be much thinner. So we can go ahead and draw them out now if you want to. But let's say we have an artery right here. And arteries, if you were to we can do like a transverse section and a cross section at the same time. It's kind of harder to draw that way, but so let's say this is an artery that's been cut lengthwise, and well, I guess, it is cut lengthwise because we're essentially kind of splicing it this direction, right? Kind of opening it up, and you're also going to cut it transversely. So what we're kind of looking at here is the formation of the 3 layers. So if you have what we call tunica, externa, tunica media, and tunica intima as your 3 basic layers of both arteries and veins, what's the difference? With your arteries, look at how much thicker your tunica media is, right? Much, much thicker, right? More collagen than, say, elastin in the outermost layer. So tunica externa is basically just the outermost layer. Tunica media is your thick muscular layer, and it's mostly made up of circular smooth muscles. So these muscles in that tunica media go around the vessel like this, right? Like this. So when the vessel wants to be smaller, then we can go through vasoconstriction. The smooth muscles will contract like that. When the vessel wants to be bigger, we can relax those smooth muscles, right? It opens like that. So your tunica media is mostly circular, smooth muscle, right? Which we can contract and relax, and that's what allows most of our vasoconstriction versus vasodilation, okay? And then your tunica intima is this innermost lining right here. So this is kind of like your tunica intima. And it's the same thing as saying the endothelial lining, right? It's the same. Tunica intima equals endothelial lining. Or the endothelium, and it's made up of simple squamous epithelium, which is nice and smooth. So what the tunica intima is giving us is a nice smooth pathway in here that doesn't create a lot of friction. What the tunica media is giving us is our ability to vasoconstrict and vasodilate. And the tunica externa is mostly going to be connective tissues that supports the overall structure, right? So collagen's a nice, strong material. Okay. So in arteries, tunica media, much more developed. So if I look at a vein, you still have the same basic layers, but a vein's going to look more like this in cross-section. Right? Much thinner, right? So when you get into veins, you still have the same basic 3 layers, right? So tunica externa, tunica media, tunica intima, but it's much thicker and stronger in that tunica media layer, right? When you get into veins, same 3 layers, but it's thinner, right? So let me put that out here. And let's say more distensible, right? It's able to be stretched out with ease, more distensible. Veins, another word we can use to describe veins is they are convergent. Like a lot of times the venous system, I mean, it's continuous, but when they talk about the origin of the venous system, they usually start very distally and it works its way back, right? So if I'm in, like, say, the hands, I got veins here, 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 here on, front, back, both sides. And they're all kind of dumping into this, what's called dorsal venous arch, right? On this side, they're dumping into basilic and cephalic veins. So they're very numerous out here, but as we get into the forearm, they become fewer. You see what I'm saying? So that's convergence. So divergence, or something that's divergent, is branching the further away it goes. Right? Convergence is the exact opposite. Convergence, you start with all the branches and they join together to form fewer. So that's why when you get to the heart and we're talking about venous return, we're only talking about like 3 vessels at that time. You have like a superior vena cava, which is draining all of the head, neck, and arms. You have inferior vena cava, which is draining all the lower extremities plus everything in the digestive system, right? The whole, abdominopelvic cavities are all draining through the inferior vena cava. And then the coronary sinus, which is draining all the heart veins, right? Because they converge. So as you get closer and closer to the heart, they get fewer and bigger, right? So again, it doesn't seem like that's such a big deal. But if I have a clot that forms in a vein, let's say here, no big whoop, right? Breaks loose, it can travel freely because the vessels are getting bigger. But let's say that clot gets to the heart and now it's being pumped out into an artery. Well, guess what? Eventually you're going to get to a place where it's going to be too narrow to keep going. So venous clot, like a thrombus that might have developed in a vein, can end up becoming what's called an embolus, clot on the move. And then once you get into arteries, which are divergent and they're getting smaller as they progress further out, eventually that's going to create a problem, right? So that's kind of a good thing to understand about divergence versus convergence. But at the same time, as you're diverging out and you're becoming smaller, that's also helping to maintain pressure. Okay? And then veins, just to kind of continue what we have going here. Again, you're made up of the same basic layers. Both arteries and veins have tunica externa, tunica media, tunica intima. Big difference, though, is the arteries have a much thicker, stronger, more well-developed tunica media. Veins, theirs is much thinner, more elastic, right? And they have more elastin in their outermost layer, too. So the veins don't maintain pressure nearly as well as arteries do. Arteries are always supposed to be the higher pressure end because we're always trying to go down what's called a pressure gradient. So we need veins to be able to distend more, which they're able to. And because they're more distensible and they're actually more numerous, let me put that in there too. You have about twice as many veins as you do arteries, believe it or not, even though they seem to always run side by side. They end up being what's called volume reservoirs. So they can actually store more blood than what I normally keep active in circulation. So during an emergency situation, I can squeeze the veins and get more blood in circulation. So they're what's called volume reservoirs. That's the same reason that jugular reflex works. Like if I go and I compress the liver has probably the most veins of any part of the entire body. You have what's called a hepatic portal system inside of there, and it's draining your entire abdominal pelvic cavity, right? So when I go and I compress that liver, your liver is a large blood reservoir. There's a lot of blood in the liver, right? And so when I compress that and I send a lot of blood back into that inferior vena cava, it backs up superior vena cava. And so in a patient whose heart can't handle that, you start to see that jugular vein stick out. But again, this is useful to serve as a volume reservoir because, again, when I'm under stress and my sympathetic nervous system kicks in, I'm going to maintain higher pressure by constricting the arteries. So that's going to increase my perfusion power, like how deeply we can get the blood to go and how much blood we can send to an organ. But I'm also going to kick in my volume reserves, right? So we have more blood that can circulate around, right? That's more oxygen carrying capacity, which is going to be more metabolism that you can do. So both are very useful. But again, what if, we're not normal? This is always describing, when we go over normal physiology, it's describing what we expect to see in a normal, healthy patient. But, what if we're chronically hypertensive? That means this is too much, right? How could I relax that? Right? So we'll have to talk about different things that cause vasoconstriction. Or if I'm hypotensive, what's a way that I could help fix that maybe? Right? So maybe if I can kick more blood from my volume reservoir into circulation, that can maybe help boost pressure temporarily until you get blood into a person or replace whatever they lost. So again, all these have more application than what we ever go over, but there's not enough time to cover everything. But if you understand the idea, then you'll get it, when the situation comes up. So arteries, again, veins. A lot of our discussion, though, gets into capillaries. It's called microcirculation. Reuse that sheet, but see through it too much. So most of our discussion comes up with microcirculation, kind of where the two sides meet together, right? So when I end up drawing the capillary, like I drew in fluids and electrolytes, here's my artery side. This is what's called an arteriole, my capillary, my venule, and my vein. And this is where the rubber kind of meets the road, because what's the point of having a cardiovascular system and circulating all this blood around if you can't get it to the tissues and exchange can't take place, right? So if exchange isn't taking place, then none of the other stuff matters. So this is going to be my capillary. This is my artery. This is my arteriole. This is my venule. This is my vein. If you want it to kind of draw detail or anything like that, again, this is a diagram. It's just representative of certain things. It's not anatomically correct, but your arteries are going to be the thicker, stronger vessels. Arterioles are just microscopic arteries, right? So these will be the thicker, stronger ones. So this is going to be our high pressure end. because when you have a lot of blood in here, that fluid's going to push against the walls, and the walls are simply going to push back. It's going to say, nah, not going anywhere, right? We talked about that in fluids and electrolytes. And I think I described these things in fluids and electrolytes too, so I'm not going to write those back out again. But arterial, microscopic artery, still an artery, still has 3 layers, but it's just small, right? Capillary is the smallest of all the vessels, also the most numerous. It's basically just an arteriole minus 2 layers. So this wall that is basically all that forms the capillaries was the endothelial lining of your arteries and arterioles. It's just we've shed the other 2 layers, right? And under pressure, it will leak. It's permeable. That's the whole point of a capillary, is it's supposed to be permeable, right? So fluid can come and go. So when you get into the venous side, again, this is continuous. So the capillaries kind of go on and form the veins, if you will, which were formed by arteries. So arteries essentially form everything. And the aorta is the main artery that's going to form all the other arteries because they're divergent. So that's why when I said earlier that the aorta is basically where all your other vessels come from, this describes that a little bit. But over here in the veins, they're much thinner, so they're more distensible. So that keeps this side, the higher pressure side, that keeps this side, the lower pressure side, because if I do get more fluid into a vein, it can just simply distend out further. And local regulators can come in and make sure it stays that way. You know, we could have nitric oxide maybe being released, or acetylcholine maybe being released to make sure that this side stays lower than this side, right? So you can actually change tone at the microscopic level. It doesn't just have to come from the medulla and all of a sudden we're doing all vessels equally the same. It's all controlled at very localized levels, believe it or not. I could have hypoxia here with high CO2 levels, and we could travel through this direction, and I could have, you know, high O2 and low CO2 levels here, and we can bypass this altogether if we want to, right? And we can divert blood to places that we need it to go. But again, we don't want to get into complex drawings, but the big idea is microcirculation is where a lot of physiology actually takes place. Like a lot of the decisions actually get made at small levels. But some basics of how capillaries work is we need to be able to take the substances that are dissolved and floating around in blood and make that available to the tissue space out here. So you have what's called the intravascular space, which is primarily going to be made up of plasma, right, with circulating cells and plasma proteins. And capillaries are permeable, but they're not permeable enough for cells and proteins to normally move through. So when we go through the process of exchanging fluid between the intravascular space and the interstitial space, the big stuff gets left behind. So that's why it gets called filtration, right? So filtration, pushing of substance and ions from the capillary to the interstitial space, right? So we'll label this, we'll put interstitial space out here, and this is where the cells live. So I'm just going to draw a couple cells this time. Boop, 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 boop. So obviously there's more cells than that, but still. So here's the intravascular space, which holds blood, which primary composition of blood is mostly plasma with cells and plasma proteins dissolved in it. So when you go through filtration, the plasma is leaving, but it's without the cells and the plasma proteins. So sometimes it's called like exudate, but still, it's just filtered blood. So the fluid portion of the blood is leaving, but cells and plasma proteins stay behind, right? So the main driving force for that filtration was, again, CHP, capillary hydrostatic pressure, because that's pushing away from the capillary to the interstitial space. But you also have a little bit of drawing power, like sucking power, in the form of interstitial colloidal osmotic pressure, or ICOP. And it's just because there's protein out here, right? Even though there's more protein in here, but still that will suck some water toward it through osmosis, movement of water through some type of semi-permeable membrane towards solute, right? So there is solute out here, it will draw water toward itself. And that's how we take things like nutrients, like dissolved glucose, vitamins and minerals, right, out to the cells so the cells can metabolize. And at the same time, in capillaries, oxygen and carbon dioxide can move, but they move through diffusion. So let's not talk about those today. We'll talk about those Thursday. Okay. So we're taking the nutrients dissolved in the plasma out to the cells. The cells will metabolize, they generate waste and products, and we need to get some of that fluid that just left out here back in again too. We can't just leave the fluid out there or the body would just swell, right? So we need to deliver nutrients, right? Let the cells metabolize, and then we need to pick that fluid back up again. And with that fluid, we'll bring in any waste or metabolites so the blood can then carry it to the right organ or system to remove it, and maybe any type of products that we need to deliver elsewhere, right? So to get fluid back in, we go through a process called reabsorption, and reabsorption is mainly going to be controlled by, so reabsorption, which is always going to occur on the venous side of the capillary, versus filtration, which always occurs on the arterial side of the capillary. Reabsorption is mostly going to be controlled by capillary colloidal osmotic pressure, which is primarily generated by albumin, which is a plasma protein, and plasma proteins don't filter out because they're too big, so they stay in high concentrations in the blood. And because we have a higher protein concentration in the blood than we do in the interstitial space, that naturally draws fluid back in. So the main driving force for reabsorption is capillary colloidal osmotic pressure, and albumin is what establishes most of that, along with other plasma proteins. But you also get a little bit of what is called interstitial hydrostatic pressure, which will push fluid back in toward the capillary. So plus IHP. So when we were in fluids and electrolytes, we talked about, well, what happens if you do get fluid stuck out here? Well, we could increase the IHP, like a compression stocking, but we actually have a system already set up in the body that gets rid of that extra fluid as long as it doesn't accumulate in too high a quantity. So let's talk about that other system. And then let's talk about like why we might have too high quantities of fluid out there, right? So, and we're going to draw this picture a couple of times. So again, without worrying about labeling everything, here's my capillary, artery, arterial, venular vein, so we know the direction of flow. Filtration is going to occur on this side. Reabsorption is going to occur on this side. If this is my artery, this is my vein, okay? One other thing that we might want to mention, and we mentioned this in a different chapter in anatomy too, is filtration is naturally always greater than reabsorption. So filtration is naturally greater than reabsorption. Usually reabsorption power is about 90% effective for whatever you filtered out. So it doesn't matter what the number is. If I filtered out 10 milliliters here, then 9 milliliters get sucked back in. That's just how strong the forces are, okay? So eventually what's going to end up happening is fluid will start to accumulate in this interstitial space, which of course will generate more interstitial hydrostatic pressure because the hydrostatic pressures are being generated by the fluid volume itself. So inside the capillary, the fluid volume pushes against the walls, and when I'm in an artery, it can't go anywhere. So that maintains high pressure, right? Because these arteries aren't very distensible. They just push right back equally as much as the fluid is pushing against the walls, right? I mean, they're slightly distensible, but not much, okay? So when I get to the capillary, now that we don't have these resistive thick walls, when you push on the walls, it just leaks out, right? And we call that capillary hydrostatic pressure. That's what pushes the fluid out there. But as more fluid starts to accumulate out here, you start to get more IHP, right? And so we have a natural system already set up in place that can start to pick up some of this extra fluid because if filtration is always naturally greater than reabsorption, that means I'm going to accumulate fluid out here. So that's where your lymphatic system comes in, right? So your lymphatic system is there to pick up the extra fluid. And eventually it's going to deliver it back to the cardiovascular system because if I'm constantly leaking fluid out and I don't get it back in eventually, then eventually we're going to go into shock, right? We're not going to have enough circulating pressure left. So this fluid will go back toward the cardiovascular system. But your lymphatic system is picking up that extra fluid that gets left behind because filtration is naturally greater than reabsorption, right? But the nice thing about the lymphatic system is along the way, we're going to clean it too, using things like lymph nodes And then eventually we can dump it back into circulation at some type of collecting duct, right? So that's another concept. But again, what if I accumulate too much fluid out here, right? If there's too much fluid out here, then we might call that edema. So let's say that for some reason the lymphatic system gets blocked, right? And I've already maximized my amount of reabsorption. Maximized reabsorption is about 90% anyway, right? But let's say my lymphatic system gets blocked. Well, then you're going to start to generate edema, right? Swelling, because you have too much fluid dumping into that interstitial space, and that edema can actually go on to affect your blood pressure, right? If you become too edematous and the blood's in the wrong compartment, then blood pressure can start going down. So you can have a swollen body and be hypotensive, even though you're waterlogged, right? You can have a lot of fluid volume in the body, but it's in the wrong compartment, right? So patients that are too edematous might also be hypotensive, right? So what do I do? Well, again, one thing you could do is you could increase interstitial hydrostatic pressure, because that's not only helping reabsorption, even though we can only get so high, but it's also what's feeding into the lymphatic system. So sometimes putting compression stockings on can actually help with lymph flow, right? But if you end up having some type of lymphedema, they might call it, then something inside of here has prevented normal drainage, and you start to swell pretty massively. Right. So if somebody has like lymphoma and they're getting radiation treatment of this, it's going to create a ton of debris and local swelling, and that's going to prevent any forward flow. So all this fluid just gets left behind and you just get massive swelling. So again, sometimes you'll see patients kind of milking it, you know, where they're constantly trying to squeeze on it and push fluid back, and they'll wear compression stockings all the time, trying to fix that drainage. So under normal circumstances, though, you know, we don't all have lymphoma, but certainly we've all experienced localized edema before. Where does that come from? It probably comes from inflammation. So when you get localized edema and it's not extreme, you know, where your skin's not shiny or anything like that, but let's say it's red and hot and swollen, you know, that probably came from some type of inflammatory response or inflammation. And what happens under inflammation is we release chemicals that change the permeability of capillaries. And instead of having these little tiny openings, which allow small amounts of fluid, you know, normal amounts, but still relatively small, in small substance and ions to leave, under inflammatory conditions, so under inflammation, your capillary becomes extra permeable, right? And part of the reason we're trying to do that is we're trying to clean the space out so you get a lot more filtration, but you're also trying to take things like white blood cells or leukocytes from inside of the vessel and allowing it to squeeze out of the vessel. So you need to open the spaces for that to happen. So whatever caused the inflammation, we can clean up the debris, because a lot of times inflammation comes from cell damage. And whether that was because some type of foreign invader got in there, or maybe you just strained or sprained the area, the cells, for some reason, either got irritated or destroyed, and that released chemicals, right? So we need to clean up that mess, because you're going to have cell debris floating around out there. And that cell debris, believe it or not, can start to generate more interstitial colloidal osmotic pressure. So that further increases the amount of fluid that's leaving. So not only do you have more permeability in the capillaries, which is going to allow more fluid to leave on the arterial side, you're also going to generate more interstitial colloidal osmotic pressure from the cell debris itself, right? So that's going to end up contributing to osmosis out here. So again, this could create some type of localized inflammation. So usually you get the rubor, tumor, dolor, and calor because of that, right? But as long as it's within reason, it's not such a bad thing. We kind of leave it alone for a little while, unless it becomes too extreme, because you can get a loss of function if it becomes too extreme, and that's usually associated with things like compartment syndrome, or it can just be very painful if it becomes very extreme. But if it becomes super shiny in appearance because it's so swollen, then that could be a very bad thing, right? So they might actually even have to go in and cut the skin just to relieve the pressure. But sometimes compartment syndrome usually comes up if there's a very small area that doesn't like to be compressed. So let me show you an example of that maybe. Let's say Google. So think about like the shin. Let's get rid of, how do I get rid of that? Manage settings. Oh, let's turn that off. Blur filter off. Off. Okay. Okay. Go back. All right. Go back. Okay. All right. Go back. Okay. Oh, there we go. So yeah, here they're relieving the pressure. Here they had to relieve the pressure. Don't worry about that. Kind of here, you can see that reflection right there that you're seeing on that. So this is very, very swollen. Obviously, you can see a lot of blood loss in that area. None of these pictures are ideal. Here we go. Here we go. Check that out. See that real shiny appearance? And I know this person's leg shaved, so they're probably about to come in and relieve this situation, right? But they're just kind of showing you that swollen shininess. So if it happens to be an area where you have a lot of blood vessels and nerves really tightly packed to begin with, like in forearms and calves and stuff like that, then that pressure can become too great and you'll get loss of function. So basically anything below the area can start to be starved of blood and nerve supply and it'll die. So you have to come in and relieve that pressure. So maybe bad burns or bad injuries could cause that. So that's essentially what they're doing in all these things, is they're relieving some of that pressure. But most of the time when you have inflammation, you'll probably get erythema. So normal inflammation, let's see, I don't mean like erythema nodosa, but just normal erythema, normal redness. Let's just take it off actually. So it's only going to go to one type. Normal redness, normal swelling. Right. So even, I mean, it could be arthritis. Arthritis is inflammation around a joint. So inflammation can show up anywhere. Could come from a bug bite, could come from a rash, could come from some type of infection, but it's just basically localized area where your vessels have become more permeable. Here, you're actually seeing what's called diapedesis, where the white blood cells are moving across the blood vessel wall out into the area, because if I need to remove any type of cell debris or any type of invading organism, these are going to be the cells that need to do it. And under normal circumstances, a cell couldn't leave a capillary, so the capillary itself has to become more permeable. So that's essentially what inflammation allows for. It's meant to be a good thing. It's a cleaning mechanism, but if it's too great, it can be a bad thing. And we would literally need to treat then the inflammation itself. So anywho, one last idea that I want to go over with you, dealing with capillaries and flow, is we don't always have to go through capillaries. And I probably did mention this to you before, but just in case I didn't, I do want to mention meta-arterioles real quick, just in case you might have missed it. A meta-arteriole is a connection that we usually can get between an arteriole and a venule, right? So let's say this is an artery, this is my arteriole, this is my venule, this is my vein. Arterioles are just microscopic arteries. Venules are just microscopic veins, and they actually connect as well through something called a meta-arteriole, which is sometimes referred to as an arteriovenous shunt. It just goes directly from the arteriole to the venule. So what determines the direction you go in is going to be sphincters, right? Like you have what's called a precapillary sphincter that exists right here, which is just a well-developed band of circular muscle. And then you'll have sphincters before the meta-arteriole, right? And what's going to determine whether we go this way or this way is usually going to be the presence of CO2 and H+. So if we have high amounts of CO2 and H+ in this area, then that will cause this sphincter to relax and blood will come through the capillary, right? But if I'm relatively low in CO2 and H plus, right, and let's say relatively high in O2, let's say this is relatively high, these are relatively low, there's really not much going on, then we will, squeeze this down. So it's saying no entry. So this will get squeezed down, right? It'll go like that. And instead, this will relax, open up, and blood will just bypass that area. So the nice thing about that is normal cells usually aren't within or no further away than like a 3-cell width from any capillary. So you're going to have capillaries that are going everywhere. So let's say that this is an arteriole, and here's like a capillary, and here's another capillary, and here's like another capillary. You know, we're not going to go everywhere equally. So if you have cells here that are hypoxic, they're low in O2, but high in CO2, and hydrogen ions are, you know, a lower pH as well. That's another trigger mechanism, but it's basically because CO2 is a weak acid and hydrogen ions are acids. And let's say this area is high in O2, this area is high in O2. We can bypass these two areas where we're essentially just going to go around the capillary bed, right, and keep going through meta-arterioles while we'll spend time to go through this area. So this way, this area here, which is the more demanding area, gets the lion's share of nutrients and oxygen, while we're just going to bypass these so we can keep it rich in oxygen and nutrients until we get to the next place, because this area says, hey, we're fine, come back, check on us later. It says, all right, no problem, I'll go around you. And this area says, hey, we're fine, don't worry about us, come back and check on us later. It says, all right, see you later, right? So that keeps this blood moving at a higher velocity, plus it's staying more nutrient rich. While this area, we are going to go ahead and go through the capillary here because we indicated that we had more metabolism going on, so we needed to get more blood to that area, right? So blood doesn't travel equally throughout the body. It travels where it's needed most, right? And local factors will determine that. So another idea. But how could you bypass an area if you needed to? You could go through something called a meta-arteriole, right? So we have talked about blood vessels, some of the differences between arteries versus veins. Right? We talked about capillaries. We even mentioned meta-arterioles. We talked about filtration versus reabsorption. Let's talk about a couple problems. Kwashiorkor, nephrotic syndrome. Okay. So once you understand how normal works, abnormal, it's pretty easy. And it helps to explain the important aspect of normal, right? So when we're going through capillary, what do we want? Filtration occurring on the arterial side, reabsorption occurring on the venous side. What's driving, or what's the main driving force for reabsorption? It's the presence of plasma proteins. It's the presence of plasma proteins, right? And if I have a higher concentration of protein inside the vessels than I do in the interstitial space, fluid will naturally get sucked back in through osmosis, right? The movement of water through some type of semi-permeable membrane, which we have here, toward areas of higher solute concentration, right? That's what's generating most of our CCOP. But what would happen if I didn't have enough plasma protein, right? And so plasma proteins, which are normally too big to filter out, right? They're something that's made by your liver, right? Normally not excreted by the kidneys, right? Are generally going to be found in high concentrations in the blood. That's where they should be because they're plasma proteins, right? And they drive reabsorption. But what would happen if I can't make enough plasma proteins, right? So it could be some type of dietary problem. So if I don't have enough plasma proteins, what could cause that? Well, it could be diet, could be a liver issue, right? Because I have to have basic building blocks to make plasma proteins. So you have to have protein in your diet, right? Because we have to break that protein down into amino acids, and then your liver can rearrange those amino acids into the type that's supposed to be floating around in our blood, you know, like fibrinogen and prothrombin and angiotensinogen, and albumin. Albumin being the most abundant of all the plasma proteins. So you need proper diet and you need proper liver function. But if I don't get enough protein in my diet, right, that's what we call kwashiorkor, right? And that's generally just protein malnourishment. And if I have protein malnourishment and I can't make enough plasma proteins and I can't generate enough CCOP, then I'm not going to be able to reabsorb enough. So I'm going to get fluid stuck out in a space. So with kwashiorkor, it gets stuck out in the abdomen and they end up getting ascites. So here, fluid is stuck in a space. Pretty easy, right? But you could also have a liver issue. You know, if I have any type of cirrhosis of the liver. So if you have cirrhosis of the liver, usually means you have scarred, damaged liver. And most of the time that comes from alcohol, but it doesn't have to. Like alcohol, believe it or not, is pretty calorie intensive. You know, that's why I try to avoid it. You know, I love the feeling of alcohol, but I am not willing to, you know, consume 6 kilocalories per gram, and it just doesn't work right with me. And your liver doesn't like that either, because when your liver starts to get very fatty, fatty material in the liver starts to become fibrotic, and it creates cirrhosis. And you can get, you know, non-alcoholic fatty liver disease, which causes cirrhosis, but the more common reason a person gets liver cirrhosis is from alcohol. And so that can damage the liver, and the more cells you have damaged, the more likely you are to see things like edema, swelling, large distended abdomens in people. So that beer belly, you know, comes from a large damaged liver. And so they can start to get other issues as well. So if I don't have enough plasma proteins in the blood, fluid's going to accumulate and you're going to get swelling and edema. So maybe I didn't get enough because I'm protein malnourished, or maybe I have some type of liver problem. But you could also be getting enough in the diet, but you just can't keep enough, right? So not enough, you know, things to work with, or maybe I have a problem with plasma proteins because I'm getting it, my liver's making it, but I can't hold on to it, right? Can't hold on to it, right? And that usually is going to have some type of that's going to deal with some type of inflammation of your glomerulus. So some type of glomerular inflammation. So, oops, well, that says inflammation. So let's look at your kidneys real quick, even though I know we haven't gotten to the renal system again. This is all pretty much review anyway. Your main functional unit of a kidney is a nephron. And the first part of your nephron is a non-discriminative portion called your glomerulus, which is just basically a big capillary. And from your glomerulus, which works like a normal capillary, we should filter, right? Your glomerulus is your main filtration unit of the nephron. And then you have what's called a tubular system, which is going to be a proximal convoluted tubule, a loop of Henle, a distal convoluted tubule, and a collecting duct, right? So here's my sometimes called a renal corpuscle, but it's my glomerulus plus a Bowman's capsule, afferent, efferent, arterial. Here's my tubular system, right? The basic function of your glomerulus is filtration, which literally works just like we said with a normal capillary. So how do normal capillaries work? Well, we filter out the small stuff, which would be the intravascular fluid, the plasma, while the big stuff stays behind. So what's the big stuff that stays behind? Cells and plasma proteins, right? They do not filter. They do not filter. So they're still in here once we get past filtration, and they carry over to the venous side. Again, as long as there's not inflammation going on, these should carry over, because they should not have filtered, because the openings in the capillaries should be too small, right? Only the fluid and the substances dissolved in the fluid should get out, right? But what if I have inflammation, right? We said that these openings get bigger. So if I end up having inflammation of my glomerulus, which is basically just a big old capillary, guess what's going to happen? Some small plasma proteins are going to get lost. And the smallest of all the plasma proteins, guess what? Which one that one is? Albumin So you get albuminuria. Albuminuria. You get albumin in your urine, right? So sometimes when you have a lot of protein loss in the urine coming from some type of generic glomerular inflammation, that ends up being called nephrotic syndrome. Okay. I mean, you could have an active infection, which we might call acute glomerulonephritis, right? But one that presents very well with what we're talking about. I mean, it's not a good disease, but presents very well for what we're talking about is nephrotic syndrome, because the main signs and symptoms of nephrotic syndrome is you get pitting edema everywhere, especially around like the eyes. So they start to get what's called periorbital edema, right? So they're consuming protein, their diet's normal, their liver's functioning appropriately, they're making protein, but they're having a high protein content in the final urine product. So their urine probably looks like this, right? Right? So when they pee out, their urine is probably very frothy. It's probably cloudy. Let's see. Like kind of like this. That's probably beer. That's what that is. But it's probably pretty cloudy. You know what I mean? So it's frothy and it's cloudy. And when you measure it with a dipstick, it's going to have high protein content. That's what's making it cloudy and frothy. So these people are consuming protein. They're making plasma proteins, but the kidneys are losing it for whatever reason. So it's the kidney's fault. So high protein loss, sometimes we associate that with what's called nephrotic syndrome. So again, why would inflammation of the glomeruli cause loss of proteins? Because your glomerulus is a filter. It's a capillary, right? And under inflammatory conditions, we release chemicals that make your capillaries more permeable, right? So sometimes that is not good when they become too permeable, especially if you're in the kidneys. So signs and symptoms of nephrotic syndrome: pitting edema, that's what you're seeing right here, pitting edema. Periorbital edema, so swelling around the eyes, that's what you're seeing right here. Right. Fatigue, weight gain, it's mostly fluid, low blood albumin, right? So that's called hypoalbuminemia. And you're also going to see it higher in the urine product. That's what I was talking about earlier. So a lot of times when you're dealing with kidney issues, and we'll talk about this more with the kidney itself, it's a comparison of two things. When you have kidney problems, there's two things we can compare. We can compare blood sample with a urine sample. And this is the general overall idea. If you understand the general overall idea, you understand kidney problems. But the blood will start increasing in waste, decreasing in nutrient, and the urine will start increasing in nutrient and decreasing in waste, because the waste is getting left behind. So if you have kidney problems, one of the main jobs of the kidneys is to remove chemical waste. So if the kidneys are not functioning very well, then I'm not going to see as much waste in the urine. It's going to get stuck in the blood. So we see increased waste concentrations in the blood, decreased waste in the urine. But another thing that the kidney should do is they should conserve certain things, right? Certain things should not be lost, like protein. So if I start seeing high protein concentration in the final urine product, that's a bad problem, right? So you might start to see a loss of certain things that we don't expect to lose, right? So, but that's general kidney function right there. And when that's not working very well, then we call that kidney disease or kidney failure, right? Renal failure. So increased waste in circulation is a good sign of renal failure, right? Decreased urinary waste output is also a sign of renal failure. Let's see. Pressurizing the blood. A lot of pressurization of the blood starts in the heart. You know, that's where we're generating it, but through the arteries, and the arteries having what's called elastic recoil in their walls, that's what keeps the pressure, right? So that's why you call arteries a pressure reservoir. It's mostly due to the natural anatomy of the arteries. And because you have that thicker tunica media and a greater ability to contract, then the arteries are able to maintain pressures. And of course, we can modulate that so it has a normal built-in ability to maintain pressures just because they're thicker, right? So again, if we're just looking at kind of like cross-section here, This tunica media in arteries is thicker. So as blood inside starts to push against the walls have a certain amount of built-in elastic recoil that pushes back. So that keeps pressure high on the artery side. When you get into the venous side, it's not nearly as thick. So when you have a large amount of fluid heading into veins and it starts to push, the veins will just simply give, right? They're more distensible. So veins are more distensible. So even if a lot of fluid does enter, it still can maintain a lower pressure than what we should see on the arteries, because arteries are naturally built. When you start pushing on them, they push back, okay? And then we can modulate all that too. So this is naturally built into their basic composition, just the way they're built. But then I can further modulate that by adding vasoconstrictors and vasodilators, okay? So if I want arteries or veins to become tighter, right, then that's vasoconstriction. If I want them to become looser, then that's vasodilation. And the reason that's important is one of the main contributors to pressure and peripheral resistance is vessel diameter, right, or vessel radius. So vessel radius / vessel diameter is one of the most powerful contributions we can apply to pressure, because there's a slide that you'll see in the notes. And again, I'm just trying, I mean, you can read through the notes at your own leisure, but there's certain things I want to touch on. There's certain things that can affect arterial pressure, you know, heart action, blood volume, peripheral resistance, viscosity. Heart action's a pretty easy one. That's just how hard the heart's beating. So if I push more blood through stroke volume into circulation, then that's going to have more push against the walls of the arteries, and the arteries will naturally be able to push back, right? The elastic recoil, right, along with how much blood the heart is pushing out per beat, generates pressure, obviously. That's kind of a duh thing, right? How much blood is in the blood vessels, right, contributes to how much it's going to push on the walls, right? Because if I have a lot of blood volume, that's going to be pushing on the walls more than if I had less blood volume. And blood volume is actually the most directly proportionate thing to blood pressure, right? So generally, if you have high blood volume, you're going to have high pressure. If you have low blood volume, you're going to have low pressure. But also peripheral resistance gets into it too. So how easily is blood allowed to travel through these vessels once you leave the heart? That has to deal with peripheral resistance. And the biggest contributor to peripheral resistance is vessel radius or vessel diameter, right? Which we can readily control, which is nice, right? Because I can control how hard the heart's working, right? Kidneys, a little bit slow, but they can control blood volume. So this is going to take a little bit longer to fix than if I were just to increase heart action. But even if I have a high blood volume, I can just tell my vessels to relax a little bit more and it won't spike pressure too bad, right? So we can just allow the vessels to relax a little bit more. So that's why a lot of times when you have a high blood volume, you'll start to see your vessels pop out of the skin because they're relaxing, they're swelling more, right? And it's the veins that you're seeing. But if I ever want to increase pressure, which we do sometimes under stress, right? Like when I'm exercising, I need blood to get into the muscles deeper, right? When I'm trying to think real hard and get out of a stressful situation, I need blood to get to the brain better, right? I need these vital organs to be receiving these blood. So there's times under stress that we need more blood pressure. And the best way I can add pressure is just by simply changing vessel radius, right? Because that makes a huge difference on the pressure of the blood inside, right? So how do we change vessel radius or diameter? Again, you can add vasoconstriction and vasodilation. So examples of things that we use as vasoconstrictors. Norepinephrine is pretty general how I maintain tone throughout the body. But we can add to that if we want to. We can add, say, the renin-angiotensin-aldosterone pathway, which I know is a nightmare for some people. But your renin-angiotensin-aldosterone system or renin-angiotensin-aldosterone pathway, that's usually kicking into the gear whenever we have a decrease in GFR. And we'll talk about this again when we get to the kidneys, but repetition, repetition, repetition. If you have a decrease in GFR, that usually meant that you had a decrease in CHP at the glomerulus, which they sometimes call glomerular hydrostatic pressure, right? And because capillary hydrostatic pressure is just a reflection of blood pressure, right? Like if I'm in a capillary, and here's capillary hydrostatic pressure, well, what do we call that when we're not in a capillary? Well, maybe if you're in an artery, we just call it arterial pressure or blood pressure, okay? So if my GFR went down, it's probably because my CHP, or you could say GHP went down, capillary hydrostatic pressure or glomerular hydrostatic pressure, right? And if CHP went down, then we can assume blood pressure went down. Right? That's not always the case, you know. You could have a clot that went into a renal artery, but this is just the normal assumption. What's the most likely reason CHP went down? Because blood pressure went down. And then one of the most directly proportionate things to blood pressure is blood volume. So maybe we're just dehydrated. Again, what would be the most likely scenario? So this is what the kidneys are thinking every time a GFR goes down. The kidneys think, well, if my GFR is down, that means my CHP is down. That means my blood pressure is down, which means my blood volume is probably down. So let's kick in everything that we got in the body to fix this, to keep blood volume from getting any lower and to reestablish pressure with whatever we got left. So that's what the renin-angiotensin-aldosterone system does, right? So juxtaglomerular cells, I'm just going to abbreviate that now because we don't need to know it yet. In the presence of a low GFR, release renin, which is a hormone that goes into the blood. And renin will come into contact with a plasma protein that's always floating around in the blood plasma made by the liver called angiotensinogen, right? And in the presence of renin, that can convert angiotensinogen into angiotensin 1, okay? And angiotensin 1 doesn't really do anything, but as it passes through the lungs and it comes in contact with angiotensin converting enzyme, right, or ACE, then it becomes angiotensin 2, and angiotensin 2 is a very strong vasoconstrictor. So you've already got a nice vasoconstrictor in circulation now in the presence of angiotensin 2. But in the presence of angiotensin 2, we're going to increase aldosterone production, which is going to increase sodium reabsorption, which is going to increase water reabsorption. So you're going to hold on to water, reabsorb, right? And then you're also going to increase ADH production, which is going to keep water, antidiuretic. I'm not going to pee so much. I'm going to keep water, but that's also called vasopressin, which is the strongest of all vasoconstrictors, right? So now I have two very strong vasoconstrictors, and I have two things that are holding on to water thanks to my renin-angiotensin-aldosterone pathway. So angiotensin 2 is a very strong vasoconstrictor. Vasopressin is a very strong vasoconstrictor. So add that to norepinephrine. Those are your major vasoconstrictors. So bloop, bloop, bloop. So if you got a patient that's very hypotensive, what can you do? Well, give them vasopressin. Give them angiotensin 2, or you can give them norepinephrine. So what's a time where a patient might be extremely hypotensive? Maybe if they're in some type of anaphylactic shock because they are allergic to something, and that allergy caused too much inflammation of the vessels, and the vessels became too permeable, and all the blood started leaving the vessels and getting into the interstitial space. And then what happens to my blood pressure? It drops because I don't have enough fluid pushing on the walls of the vessels anymore because it's all in the wrong space. So they're going to feel all hot and swollen and itchy, right, as that fluid's leaving the vessels, getting into the skin. But at the same time, they're going to feel like they're going to pass out, right? So what do we do to treat that? Usually norepinephrine. And then down at the bottom, it says, what else does the renin-angiotensin-aldosterone system do other than increase pressure? It retains fluid. And what would increasing fluid volume do to pressure? It would keep the pressure higher, because the more fluid volume I have, the more pressure I can generate. So when is there a problem with pressure? When it becomes too high or too low, right? So hypertension versus hypotension. So a lot of times the treatment for hypertension or hypotension is remove natural things that are vasoconstrictors. So get rid of stress maybe, or maybe give the patient ACE inhibitor so we don't continue through the renin-angiotensin-aldosterone pathway. Because if I have an ACE inhibitor, right, I can't get two of my most powerful vasoconstrictors. I'm preventing, well, I mean, you can get vasopressin still, but still you're preventing the production of most of it. So if you give a patient an ACE inhibitor, that's going to be a really strong way to control hypertension because it's going to keep them from retaining water and it's going to get rid of two of your most powerful vasoconstrictors, right? If I get rid of stress, that's preventing the presence of norepinephrine, right? So if a patient's hypertensive, those would be nice. Or you could just give them a diuretic because, again, fluid volume is one of the most directly proportionate things to blood pressure. So if I'm hypertensive too high, then let's get rid of this, take it down, right? So pretty simple stuff once you know the basic mechanisms. So between hypertension and, of course, hypotension is going to be the exact opposite. There's another thing that we should cover real quick that you don't think about all the time, but it's something called pulse pressure. And pulse pressure is the gap that we end up having between systolic and diastolic pressure. So again, I'll explain where systolic and diastolic pressures come from again and what's normal. And I know we're running out of time, so if you got to go, you're more than welcome to go. I'll keep recording this even past our stop time if I have to. But pulse pressure is the gap between our systolic and diastolic. So pulse pressure normally should be 40 or less, right? So if your systolic pressure is 120 and your diastolic pressure is 80, that's super great, super fine, super fantastic, right? But the gap in between the two is the pulse pressure. So where does this come from? So the pulse pressure is 120 minus 80. So 40 or less is good. So that's your pulse pressure. Okay. Where do these numbers come from again? It's the left ventricle generating enough pressure to push against what's called peripheral resistance and allow enough blood to eject out of the ventricle. So if my peripheral resistance is about 90 millimeters of mercury, I need to go about 30 millimeters of mercury higher than that to adequately get enough ejection, right? So inside the left ventricle, I need to generate about 120 millimeters of mercury pressure, right? And that will not only force the aortic valve open, but it'll allow me enough pressure to eject adequate amounts of blood. So my peripheral resistance in a normal, healthy individual is about 90 millimeters of mercury. And that's, again, in the aorta pushing back, right? That's your peripheral resistance. That's what we have to overcome to get blood out. It's constant or relatively constant. Obviously, if I have more vasoconstriction going on because of stress, this is going to go higher. If I have a lot of atherosclerotic plaque buildup, this is going to be higher because your vessels are less elastic then. So there's a lot of factors that can cause peripheral resistance to be higher, which we'll talk about that in a minute. But normal healthy adult peripheral resistance, we can suspect would be about 90 millimeters of mercury pressure. So their systolic pressure should be about 120. That's going to give me adequate pumping power, right? And then once it drops below peripheral resistance, then we're able to refill. So my diastolic pressure needs to be lower than peripheral resistance, about 10. So that's where we get the normal numbers of 120 over 80, right? With, again, the pulse pressure being the gap between the two. But if my peripheral resistance, let's say, goes up to 100, then what's my systolic and diastolic pressure going to be? 130 over 90. If my peripheral resistance is 110, 140 over 100. So that's where we start to see like hypertension come into play, okay? And those would be normal hypertensive values. Like 130 over 90, we actually call high normal now because so many people are hypertensive. So we're just like, screw it. Let's just call that high normal so we don't have to tell them they're hypertensive, right? But the higher and higher you get, the harder it's basically implying that your heart's working harder even at rest, you know what I mean? But your heart's having to work harder to overcome peripheral resistance. So eventually the heart's going to enlarge, you'll get cardiomegaly, then it's going to fall apart because eventually you're going to get to a point where you're either too stretched out or too rigid and you'll have heart failure. So hypertension is a big deal, you know? But probably a more immediate big deal than these slow changes that might occur over time is what if you have a widening pulse pressure for some reason? That's not so good because that can kill you immediately, right? And it's not because it itself is going to kill you, but it can actually create more likelihood of aneurysms and ruptured aneurysms, right? So the problem with a widening gap between your systolic and your diastolic, like if you have a widening pulse pressure, which is basically greater than 40 millimeters of mercury, it can cause vessels to distend too much and recoil too much. And over time, that can cause micro tears, which could lead to aneurysms where a vessel balloons out, or it could cause an already present aneurysm to rupture, right? So when you start to get pulse pressures like around 80 or something like that, you're in stroke territory. Right? So pulse pressure is one of those things you also have to kind of keep in mind because it could be an emergent situation. Arteriosclerosis, atherosclerotic plaque buildup. This is the big term. This is a type. So most people, they just kind of tend to think about them as being the same thing, and that's fine. That's not such a big deal, but arteriosclerosis is just more a generic term. Like arteriosclerosis just means hardening of a vessel. And you can get that over time by calcification. Like you can get arteriosclerosis and not have atherosclerotic plaque buildup, but you can't really have atherosclerotic plaque buildup without getting arteriosclerosis. You see what I mean? So this is more of the catch-all term. Atherosclerosis is a type of arteriosclerosis. But sometimes too much alcohol and too many drugs will cause arteriosclerosis because it'll inflame the inner lining of vessels, and those inner linings over time will calcify and become too hard, right? But that's not what atherosclerosis is. Atherosclerosis is the hardening of a vessel because you have fatty plaque buildup. So this is usually associated with high cholesterol, high fatty acids. And those fatty acids can deposit in the walls of vessels. And again, that's going to cause the wall of the vessel to become harder, misshapen, rougher in appearance. So not only is this going to make it harder to pump into those vessels are more likely to form clots as well. So you'll get a decreased lumen size because this is occurring in the wall of the vessel itself. So you'll get a narrower lumen, which is a problem, especially if you're around like heart and kidneys that need a constant supply of blood. So if you have atherosclerotic plaque buildup over time, that's going to lead to things like possibility of heart attack or kidney failure, right? So if you have like renal artery atherosclerosis, coronary artery atherosclerosis, you have carotid artery atherosclerosis, those are all big deals. But I guess, again, a more emergent problem is these plaques can sometimes rupture. And when that plaque ruptures, you can actually get a fatty embolus in there, or you can form a clot because of the materials that leak out, like a normal blood clot. And either way, that's not good because that could block off here. Anything that gets dislodged could block off distally because eventually arteries will diverge and become smaller, and you're eventually going to get into an artery that's not going to be able to allow passage of that anymore. But if you have atherosclerosis, then you do have arteriosclerosis. Those will increase my peripheral resistance, right? Because the vessels are less compliant. They're harder to push against. They're going to create more resistance that the heart has to overcome. So that eventually is going to lead to heart problems. Right. Let me share a screen with you real quick. So that was arteriosclerosis. Down here says, if arteriosclerosis is the thickening and hardening of vessels, how can that lead to thinning and ballooning of vessels that we see in aneurysms? Sometimes when your walls become overly thick, they get calcified, and then those calcified walls aren't as stretchy as they used to be. It basically takes like a nice stretchy rubber band and turns it into a dry rubber band. So the inside of the wall can actually become brittle. So if I have, let's say, atherosclerotic plaque buildup in some of these vessels, a lot of times what ends up happening is the endothelial lining itself becomes calcified right there. So this gets all hard, right? And this lining starts to become calcified. So when you start to stretch, relax, that can cause these little micro tears inside of here, and blood can seep inside of there. And when blood seeps inside of there, the blood's going to find the path of least resistance, and it can cause these vessels to start ballooning out. And the more the vessel starts to balloon out, the thinner and thinner these walls will get stretched. And so that's an aneurysm. So an aneurysm is where you actually have blood traveling sometimes in between the layers of the walls of the vessels, and it starts to cause the wall to thin out. So it becomes very, very thin, right? So this might be thicker, and then it gets very thin as it gets super stretched out, right? So this, obviously, if I have a widening gap of pulse pressure, imagine that you have this strong push of blood, and then all of a sudden it collapses, and then this strong push of blood, and then all of a sudden it collapses. That's what happens when you get pulse pressure. That can cause this thing to go whoop, whoop, boop, and bust, right? So that's a problem. Most common type of aneurysms is a Barry aneurysm around the circle of Willis. So that's why stroke becomes an issue. Circle of Willis is just a area of circulation around the brain. So, and throw in a Barry aneurysm there. Just means it's, it looks like a little berry on it. Those are different places where Barry aneurysms are more common, right? Kind of a lot of them, isn't it? So these are common areas where you find Barry aneurysms, and they all happen to be around the circle of Willis. It's not the only place where we get aneurysms. Another big one where we get aneurysms is the abdominal aorta, usually right below the renal arteries, right before you get to the common iliacs. And again, you get aneurysms anywhere, but these are the ones that we worry about most. These are the ones that commonly pop up, right? So 1 in every 250 people over the age of 50 are likely to die from this each year. That's a lot. This actually, abdominal aortic aneurysms used to be the 6th most common way people died. And so we've gotten a lot better for screening for them now. You can see them on an x-ray, which is nice. So here you can actually see the abdominal aorta kind of poking out. You can see it over here as well. Right here, it's kind of oblong shaped. Here you can see the walls of it right there. I mean, sometimes you should be able to see an abdominal aorta, but it should look all nice and, let's see, let me see if I can say, let's look at a, let me see if I can show you a normal looking abdominal aorta. That's not terrible right there. You can see their abdominal aorta right here. I know that's not easy to see. Probably do have a little bit of aneurysm right there. Probably a little bit of one right there. Maybe a little bit of one right there. So this isn't completely normal, but it's not terrible either. Here you can't really see it because there's too much what's called meganblaze. There's just too much gas, but that's good. Like if you can't see it, that usually implies that we don't have a lot of calcification going on either. But when you get those abdominal aortic aneurysms, they become much more visible. Here you can definitely see the abdominal aorta right there. This is just over, this isn't part of the abdominal aorta. This is just a shadow over top of it because you got colon gas. So I know it looks like it's the same vessel. It looks like there's a perfect outline right there. It's not. This is just overlapping structures, but you can see the back end of the abdominal aorta right here. And this person's probably got dish, I'm guessing. No, they say spondylosis, so that's ankylosing spondylitis. I disagree. I say that's dish. It's a different type of enlargement. But here, again, I can see the abdominal aorta. Looks pretty good to me. Doesn't look overly large, looks pretty normal size. The outer edges are clean, right? And again, that looks like it's a problem, but that's just abdominal gas over top of it. So you have to extrapolate information from x-rays. So let me go back. But if you do end up seeing, here we go, maybe more rough outlines, like here I can see a rough outline. Like it's brighter. It's brighter, like you can see it clear. Let me make this bigger. Like see how much brighter that outline is. So again, I'm not worried about this air pocket right there. That's part of the abdomen. Here you can actually see the colon. You can see the hostrations of the colon right there. Right, so that's no big deal. That's waste inside the colon right there. Right. Probably see a turd over here if you looked for it. But again, I'm not worried about this because it's pretty disseminated all the way across the x-ray. So that's just abdominal gas. Here's transverse colon right there. Here's transverse colon, right? Sigmoid colon's going back like this. But that is your abdominal aorta right there, and you can see calcification on the outer edge. So this thing is calcified, it's more fragile, it's ballooning out. Here you can see a little bit of calcification right here. So right there, you can see that calcification, okay? But you can see the outer margins of it right here. You can see it right there. So too big, way too big. So that is an abdominal aortic aneurysm. And the problem with abdominal aortic aneurysms is they can rupture, which we usually call that a dissecting abdominal aortic aneurysm, and you'll literally just bleed to death inside. So a lot of times they monitor these once they get to a certain size, and if it gets too big, like this one is getting too big now, because if it's starting to get bigger than some of these lumbar vertebrae, that's a problem, right? So they'll go in and they'll basically cage it. But that used to be a very common way people died. Buerger's disease, peripheral artery disease, or peripheral vascular disease. Peripheral vascular disease can usually be one of two types. You can usually have some type of artery issue, or you can have venous issues. And sometimes the easy way to tell the difference between artery versus veins is, how does the extremity feel? Does it look swollen? Are we getting more issues the more active the patient is? If so, we call that vascular claudication. And with that swelling, is it bright red or is it pale? Is it hot or is it cold? That can tell me stuff. So, one of the big indicators that the patient might tell you with peripheral vascular disease is they talk about leg pain, but it gets worse with activity. And when it's worse with activity, we call that vascular claudication. There's other ways we can get leg pain. You could also have neurological or neurogenic claudication, and that's usually position related. So in certain positions, their legs will hurt, but if you take them out of that position or they move into what's called an antalgic posture, it gets better. With vascular claudication, position doesn't really make a difference. Are they being active or are they at rest? Because the more active they get, the more the vessels have to pump. And if they have some type of peripheral artery disease or peripheral, vascular disease, and it involves the veins, then the blood's not able to go through there as quickly or as well as it should. They'll get pain with the more activity that they do, and then it usually gets better upon rest. So that's, again, an indicator. So if it's a vascular problem, the more activity, the worse it gets. Same thing with the heart, right? You stress test these patients, make them walk up a set of steps and say, did that get better or worse or what? If it got better, then it's probably some type of neurogenic problem, and moving probably helped them. But if it's vascular or any type of stress that you add, more activity they do, it gets worse. So if they have lower extremity pain, gets worse with movement, that's indicating we got vascular claudication. Then go and look at it and feel it. Is it hot? Is it cold? So that a lot of times will tell you stuff. Are they smokers? Right? There's a very specific type of peripheral vascular disease called Buerger's disease that's almost 100% of the time associated with tobacco. Right? And eventually their fingers or toes, it usually starts distally and it moves its way back, will eventually have to get amputated. And with Buerger's, it's 100% of the time associated with smoking. But again, and there's different like orthopedic tests you can do on a patient to see if it's, peripheral artery disease versus Buerger's disease. A lot of times, if we just elevate the foot and if it stays like discolored, hot or cold, and, again, they're presenting with vascular claudication, we'll probably just assume it's some type of peripheral vascular disease. And you can go on and do like ultrasounds and angiograms if you want to test for that. But with Buerger's disease specifically, what you'll end up seeing is you'll have the patient elevate their foot and you look for the veins in the back of the foot to collapse. If that's the case, they have Buerger's, right? And so Buerger's, also known as thromboangiitis obliterans, the vessels will collapse when you elevate the foot. So that's an easy way to differentiate Buerger's disease versus peripheral vascular disease. And again, with Buerger's, 100% of the time, it's smokers. Right? And a lot of times, if they just quit smoking, it gets better. And then the last thing that it talks about in this chapter is blood clots versus an embolism, just terminology to be familiar with. And then common areas. So again, thrombus is just the general word that we use for a clot, right? And it usually means clot in situ. It means it's situated in one place. A thrombus is usually referring to a clot that's sitting in one place. When that clot breaks loose, if it does, then you can get something called an embolus, and that's a clot on the move. So the thrombus isn't a big deal unless it becomes an embolus usually, right? So if it's a clot in situ, yes, it can become too big, but clearly if it's still getting bigger, there's blood going by. So that's not such a terrible thing. So blood thinner should remove it, should be fine. But if that clot breaks loose and becomes an embolus, eventually you're going to get into a place where you're not going to be able to move forward any further and blood's going to be blocked. So that becomes a much bigger issue. So the ones you hear about most obviously are DVTs going on to become PEs, right? That's a deep vein thrombosis that ends up becoming a pulmonary embolus. So this is something that you would certainly want to check for in patients that are less mobile, that are seated most of the time, elderly that don't have good blood flow to begin with. So if you've already got a patient that has peripheral vascular disease, right, or they're kind of elderly, let me share screen with you again, right, then we're probably going to want to screen for these DVTs. Right. So again, a DVT or a deep vein thrombosis usually occurs in the deep veins of the leg. So the problem with that is if I just going back to basic knowledge about arteries and veins and stuff like that, some of these deep veins in the leg can be pretty large, right? So you can get a fairly sizable clot. But if they break loose, a lot of times what ends up happening is they end up forming around valves, because all veins have valves preventing backflow. And sometimes you can get a clot that forms behind a valve. And part of the reason the clot might be forming could be you have some type of pre-existing condition. You could be a smoker, a drinker, that's going to make these things more likely. If you take birth control pills and smoke on top of that, that's going to make these things way more common. But the more common people that you'll see them with probably whenever you work is the elderly, or people that have diabetes, or people that have just had surgery or something like that, and they're recovering. So again, I'm just trying to think about why you would see them in your normal everyday life. But think about an old person that sits around all day. How much circulation do they really get? So sometimes when these things are just allowed to sit there, they can actually grow and grow and grow. And around valves is a good place for blood clot to grow, because you get natural turbulent blood flow as you go past a valve. Right. And so if this forms in one of the large veins of the leg, these can become pretty sizable and pretty long, believe it or not. And if anything causes that to break loose, like maybe some type of quick change in pressure, like if they were sitting all day and all of a sudden they stood up, or if they've been bedridden, all of a sudden they want to get up and walk around. I saw something on Yahoo the other day. It said some lady died because she tried to do a kick. That'll do it. There you go. So if you have surgery, don't get up and try to kick anything. But if this thing breaks loose, you get free rein all the way back to the heart, because remember, veins are convergent and they get bigger as they get closer to the heart. So as I end up going through that inferior vena cava, no problem, right? I get into that heart, when I get into the chambers, no problem. But then when I start to get back into pulmonary circulation through pulmonary arteries, that's a problem, because as your blood leaves the heart, and you go into that pulmonary trunk, you're eventually going to start getting small again. And this bifurcation point right here, so here's the pulmonary trunk, here's right pulmonary artery and left pulmonary artery, you're automatically decreasing your size by 1/2. So sometimes it might get stuck here, and then you'll lose function of the right lung. Sometimes it'll get stuck here, you'll lose function of the left lung. But the worst case scenario is it gets stuck right here and you lose function of both lungs and you die. So that's what's called a saddle embolus. And that's why we have to be very careful of DVTs, because even though this might just cause calf pain, localized swelling around the calves, right? It gets worse if you dorsiflex the foot and squeeze the calf. That's how you screen for it, right? It can break loose, become a pulmonary embolus. And if it becomes a saddle embolus, then the patient just simply dies, right? They'll just drop dead right there. So a lot of times this ends up happening and people don't know what happens. They think they had a heart attack, but if they were seated sitting for a long period of time and all of a sudden they got up and moved and they just keeled over and died, they probably had a pulmonary embolus. I'm probably not going to get too much into blood clotting pathways. We'll talk about this more when we get into maybe blood itself. But extrinsic, remember, that's always going to be started by damaged vessel walls. Intrinsic, remember, that one's always going to be started by foreign surfaces. So when blood comes in contact with a foreign surface. But both lead to the common pathway, which is the conversion of prothrombin to thrombin. And then that will then convert fibrinogen into fibrin, which will form the clot. So extrinsic pathway, tissue damage, tissue injury gives it away. So if you get asked a question about it, look for the word damage or injury. That will start the extrinsic pathway. Intrinsic pathway is when blood leaves a vessel and comes in contact with collagen, which is going to be foreign to blood because it's normally just seen in endothelial cells. And we've actually already talked about allergies, inflammation. Shock is where you don't have enough pressure to maintain circulation. One of the most common forms of shock, you'll hear about something called anaphylactic shock, which was an extreme form of a type 1 allergy. Right? So if you have a really bad allergic reaction to shellfish or a really bad allergic reaction to foods like peanuts, stuff like that, that can lead to type 1 anaphylactic shock, in which your blood vessels will start to become permeable all over the body. And if that's the case, then too much blood will leave the vessels, dropping pressure. So you'll become very hypotensive and it starts to get out into the interstitial space. So you'll feel maybe itchy and swollen. But again, if you don't have enough pressure to keep blood circulating, then you'll die. So that's why it's important to get that pressure back up. But that is all for our blood flow and pressure. So Thursday this week, we will finish up our section and work on respiratory system and gas exchange. Next week, we will answer any questions. Thanks for sticking around, those of you that did. And for those that left early, I will see all of y'all again on Thursday. If you got any questions, feel free to stick around. If not, then have a good rest of the day.